Hello and welcome to Kickback Science Podcast. I'm your host, Dr. Luke. This podcast is your place to get the tools and knowledge necessary to navigate the world of health and wellness. So kick back, let's talk science. This is good content. This stuff has gone great. We'll jump into it. Let's dive in. Let's do a little science. I'm going nitty gritty science right now. I've been looking forward to this. Kind of going on a little bit of a tangent. Oh yeah, that's right. I forgot about that. The information we discuss in this podcast is not meant to be taken as medical advice. It is simply informative. We're not affiliated with any organization or institution, just a few guys talking science and having fun. So today's podcast is kind of for the dads a little bit.
Yeah.
Shout out to the dads.
Shout out to the dads.
I feel like since this is going to be more of like a male-centric episode, like people may think, oh, you know, if I'm a female, I'm not going to listen to it. But I'm going to convince you why this should be relevant to both males and females. I don't know how yet, but I'm going to try to because I want you to listen to our episode so it gets us more views. We'll eventually do another episode on hormone replacement therapy in females, but without foreshadowing too much, today we're talking about testosterone. I think we should focus this episode more so on testosterone replacement therapy and what that does for general health. Because we're going to have a separate episode on like bodybuilding and physique. We could touch on that a little bit today, but I feel like that would be a whole nother episode. But yeah, today we're going to talk about testosterone. Some tea.
Ooh. Ooh. I'm really interested in this one because I am a dad and I am just burnt out. And I think this might be the cause of it, like just low T. So let's just first start off. What is it? Just kind of go over the basics of testosterone.
So testosterone is a steroid hormone. Steroid hormones, they all come from the same precursor, and that's cholesterol. So testosterone gets produced through a series of steps by cholesterol, and a majority of testosterone gets produced in your nuts, so in your testicles.
Nice.
We often think of it as being primarily involved in like masculinity, male development, muscle growth, and like anger,
Bodybuilders, yeah.
But the reality is that females have a lot of testosterone too. And so testosterone is part of what we call our endocrine system. And an endocrine organ is something that responds to a hormone that's delivered in one part of the body, and then it produces another hormone, and they kind of try to maintain this constant level of a hormone and a constant like homeostasis. We've touched on a lot of homeostasis in this podcast and how your body always kind of wants to be at this nice comfy spot throughout the day. Gosh, you guys got to stop me from going on a tangent. How is that even relevant to testosterone? Are you gonna be talking about endocrine systems here? Well, no, I mean it actually does become relevant. But so testosterone gets regulated through what's called their HPG axis, where you have in your hypothalamus.
Question.
What's up?
Are you telling us right now how testosterone works?
Yep.
All
but
right.
I need to lay the groundwork of how testosterone is made, because so many people like think they have just like low testosterone, and the reality is like, what does that mean? Why is it low? Like there's so many different things that come into play instead of like, I just have low testosterone. And so
just being tired that's not going to be what is the cause.
Yeah, but a lot of people jump to like, oh, I'm tired.
Me.
I'm a man. I have low testosterone. I need more testosterone.
Gotta do more legs.
So you have this area in your brain, your hypothalamus, which is kind of like, you can think of it as like the master regulator of everything in your body. Body temperature, metabolism, wake, sleep, digestion. What also regulates sex hormone production, testosterone production. And it does that by releasing what's called gonatotropic releasing hormone, or GnRH. When testosterone or estrogen is low, the hypothalamus produces this GnRH. That then goes to your anterior pituitary gland. And the pituitary gland is pretty close to the hypothalamus, but it has this avenue to just spit out stuff into the rest of the body. So that spits out LH and FSH. You probably heard of luteinizing hormone and follicle stimulating hormone when it, in terms of like menstruation and pregnancy and menopause. Well, these hormones are also present in males, and they're called gonadotropins. And so those hormones, LH and FSH, travel down to your nuts and tell your nuts to produce testosterone. And testosterone then will be produced and converted. It could be converted to dihydrotestosterone, and it can also be converted to estradiol, or, you know, a lot of people just refer to it as estrogen as a whole, but there's a lot of different types of estrogens. We won't go down that rabbit hole. But when testosterone gets converted into estrogen, I'll just refer to it as estrogen. That's called aromatization. And it can also get converted into dihydrotestosterone, as I mentioned, through an enzyme called 5-alpha reductase. This is all going to become relevant. I promise. I know this sounds absolutely ridiculous. You're like, I don't want to go through metabolism and endocrine system physiology right now.
I thought that was the physiology right there. I was like, oh gosh, good flashbacks.
So I bring up that cycle because a lot can go wrong in that avenue. Now, when you have, you know, testosterone plays a huge role in growth and development. It plays a role in metabolic health, brain health, cardiovascular function. And so when testosterone increases, it just kind of operates on this negative feedback cycle, and your body's constantly trying to regulate it. Tends to be the highest in the morning when you wake up, and then it kind of declines throughout the day. And interestingly, testosterone is what we call hydrophobic. It doesn't just float around in the bloodstream freely like something like glucose or electrolytes do. It needs a transporter. This is relevant. And it gets transported by these carrier proteins. And then you have free testosterone. Free testosterone is the testosterone that's not bound to these proteins. The only way that testosterone can make its impact and bind to these androgen receptors, upregulate genes that increase muscle growth, and do all the things that testosterone does, the only way that that can happen is if it breaks free of these binding proteins, the sex hormone binding globulin and the albumin. And so when you go in and you get a lab test, for example, and it gives you your total testosterone, it's kind of hard to decipher what that means for people, because, you know, that doesn't tell you how much of your testosterone is bound to albumin, how much is bound to sex hormone binding globulin.
So a blood test isn't going to give you accurate numbers, you're saying?
If it's just total testosterone, no. There are some lab tests that will give you what's called bioavailable testosterone. And that is total testosterone minus the amount that's bound to the sex hormone binding globulin. And the reason is because when testosterone is bound to albumin, it can break free a little bit easier. But when it's bound to that sex hormone binding globulin, it's kind of stuck a little bit more, and it doesn't really do anything for your body there. Because testosterone has to go into the cell, and then it binds to these what are called heat shock proteins that bring it into the nucleus of the cell to actually upregulate these genes that, you know, cause all these improvements that testosterone brings. And so, yeah, it's something that I guess I should mention. As you age, you see this decline in testosterone, just like when women go through menopause and they see this decline in estrogen. same concept here, where, you see testosterone levels, they're actually kind of high when you're born, interestingly enough, but then they drop down to like 0. And then through puberty, you see this spike. And then throughout mid-30s, Joe, I saw you pick your nose. Throughout like mid-30s.
I picked a hair off the mic.
Oh, sure. Around like mid-30s, you'll peak, and then it will drop throughout the rest of your life. And when testosterone levels are low, that's when you get low libido. You've got this low sex drive. It decreases erectile function, so you get erectile dysfunction. Your mood becomes impaired. You become depressed. You're tired. You're losing muscle, and all these impacts. That
is that why you have a life crisis? You go buy a motorcycle, get more testosterone.
Yeah. So oftentimes that causes middle-aged men to go buy. That's actually really interesting.
Just saying.
Like, oh, you have low T, brother.
Hey. Yeah.
Dude, my neighbor bought a boat.
He goes out on you get checked.
Saw that motorcycle. Dang. You must have low T.
Shit, can't get it up. But
hey, I might be on to something. All right.
You
never know.
might be.
Maybe I'm on to something, guys.
So I also, real quick, I'm going to point out what DHT is, and then I'll stop freaking talking so you guys get into some questions. But dihydrotestosterone, as I mentioned, testosterone gets converted into DHT, or dihydrotestosterone, through an enzyme called 5-alpha reductase. Now, DHT has a higher affinity than testosterone does, and DHT is actually what's responsible for most of sexual development and the growth of your dick. Nice. A lot of secondary sex characteristics come from DHT. And
I feel like you should say dick.
Yeah. Why? It's really scientific.
I'm just saying.
I've been saying nuts. Yeah, but you guys make fun of me when I say penis.
No, you should. You say it like penis every time.
Dihydrotestosterone also happens to play a role in hair loss and prostate growth. And so, there's this medication called finasteride, which is a 5-alpha reductase inhibitor. So it inhibits the conversion of testosterone to dihydrotestosterone. People can use that to prevent hair loss, and they can also use it to stop what's called benign prostatic hypertrophy, or BPH. It's as you age, your prostate actually increases in size, and that can cause issues with urinary function. That's why old people have a hard time starting and maintaining a stream. If you ever pee next to a guy at the Twins game or something, just the person, he's got a big old prostate. And so you can also use this finasteride to stop prostate growth. Who knows where that's going to become.
So you'd have to take testosterone and another supplement to kind of block that from having your prostate be a balloon.
You would just have to take that. So you're still going to produce a testosterone.
Okay.
You're just decreasing the conversion of that testosterone to dihydrotestosterone.
Okay.
So people use this low dose of finasteride for hair loss, and then they'll use a higher dose to actually shut off the DHT production so that they don't have this prostate growth. That's all I got for you guys. What the hell do you want to know about testosterone?
I don't know. What are the signs of testosterone?
When would you know that you have?
You have to get a test done to know.
Yeah, absolutely.
You can't just be you can't bring it down to these certain symptoms.
Well, I mean, your symptoms will lead to maybe this is testosterone here. So usually it is
comes down to a test.
Yeah, usually it is abnormal fatigue, decreased libido, depressed mood, erectile dysfunction.
Okay.
These things can cause you, if you brought that up to your physician, you'd have a discussion of maybe this is due to testosterone. Now, the problem is when you grab a lab test, Joe, you got your testosterone checked. There's some HIPAA for you telling the world. Was it a total testosterone that they gave you, or did they give you other metrics? Because you mentioned that you got your testosterone back.
Yeah. Let me look.
And as you're looking, I mean, a lot of these labs, when they'll come back, first of all, it's really important that you measure this test at the same time throughout the day, because testosterone does fluctuate a lot in a given day. And so you want to check it in the morning, and you want to keep checking in the morning when you go in for repeat testing. But a lot of times you'll just get this total testosterone level, and it won't break down into like what's the free testosterone or what's the bioavailable testosterone, because that's actually where you see, is there an impact?
Give that a look at it. He gave me everything, it looks like, right?
Yeah, so you did get like a full panel, and as opposed to just like total testosterone here. So, and that's important to get. You know, if you can get your free testosterone, it's going to give you much more of an idea of if low testosterone is causing your symptoms. Because back to my example, Reed, let's say you and I both go in, we have the same total testosterone, but I'm having much more symptoms of low testosterone. And, you know, we both fall within the normal range, and my low testosterone just gets passed up and we don't really look any further. Well, it's possible that I do have low testosterone because my free testosterone is lower. So I'm not getting the impacts of the testosterone like you are. Free testosterone is only like 1% to 2% of total testosterone.
Is that a healthy amount? 1% to 2%?
Yeah, that's usually what is floating around. Because again, testosterone is not just like freely floating.
Yeah.
It's bound. And another reason that we could be having differing symptoms is because the difference in androgen receptors, which are what testosterone binds to. So you may have just a increased density of these receptors. So testosterone just has more of an impact for you than it does for me.
Does lifestyle have an impact?
100%. And that's
boom.
Joe, another one of those days where he's just gonna have good questions.
So, all right. Well, why don't they just add that to a yearly physical?
There's a lot of things that should be added to a yearly physical. It just takes a lot of time for the medical system to update to where we're at. You know, we just kind of.
I mean, they're taking your blood anyway. Fucking add a vial.
Well, there's a.
I bet you more men would go in yearly if they could check their
100%.
testosterone levels every year.
The thing is, when you go into the doctor, if they're going to order a lab test, the only time they're ordering a test is if they're going to treat an abnormal result. And so a patient comes in, and if they just really want their testosterone checked. You know, a lot of clinicians are going to not want to do that because it's like, well, I don't think you're having any symptoms. And if you have an abnormal lab, I have to treat you ethically. You know, they're supposed to treat an abnormal value, which, you know, you could argue.
So they just don't want to do the fucking paperwork, basically?
No, not at all. It's just like they are trying to save you from being put on unnecessary treatments. Or like some people are like, oh, I want a full body CT scan. Like I want to see if I have cancer. It's like, well, okay, I can get you a full body CT scan, but what if I see this random little mass on your adrenal gland? I can't ignore that legally. We have to go in and check out what that is. We have to figure out what that is now, because let's say 10 years down the line, you die of adrenal cancer and that doctor ignored it. He's getting sued to shit. And so there's a lot of tiptoeing around ordering unnecessary lab tests.
But wouldn't you consider testosterone an unnecessary check?
I do.
Okay.
But I think that there's a lot of clinicians who still are not up to date on that. I think people still don't feel testosterone should be something that you check regularly. It shouldn't be checked unless you have symptoms, for example, which I could make an argument for.
I suppose, but
like, I guess unnecessary costs. It's like, why are they charging me for testosterone? I don't have any symptoms of that. And then you get a bill for checking.
Okay,
that.
at least make it an option rather than like, for me, I got I just got to check because it was my first physical in like 15 years.
Oh, I haven't done one since
Since
football.
2009.
Yeah.
Yeah, it was 2009. I got my last physical.
Oh,
Same.
and did your doctor just like willy nilly, like, let's get you a testosterone? Or did you have to-
I asked and they did it. So
Sweet. Yeah, not a lot of physicians probably would take that approach.
yeah, I just did it.
Yeah, that's cool. And you got a full panel, which is good. Now you asked about lifestyle.
I did.
So what's pretty crazy is you could come in to the like clinic and you could get a low testosterone, which I guess we should highlight for people. Most of the time, low testosterone is diagnosed off of total testosterone, and it's anything less than 300 nanograms per deciliter. Some people will use 250 as the metric there for total testosterone. And so let's say you've got, a low testosterone. It is very possible that you just didn't sleep well and you're really stressed, and that's causing this decrease in testosterone. High cortisol levels and lack of sleep decrease testosterone in an incredible amount, and enough to push you into that low testosterone range. And so then you get thrown on testosterone replacement therapy, when in reality, if you focused on lifestyle factors, something like, what do you think increases testosterone?
Exercise.
Something like exercise and sleep to increase your testosterone. And I'm not talking just a couple points. Like, you significantly increase your testosterone as much as if you were to go on testosterone replacement therapy at times. So it's really important to take a step back and be like, okay, I'm feeling fatigue. I'm depressed. Like, yeah, maybe my testosterone's low, but how have I been sleeping? How's my stress level? Have I been exercising?
Been hitting that McDonald's too many times.
McDonald's.
So nutrition, that would play a factor too in your testosterone levels. Like crushing McDonald's all the time. Would that affect it at all, or not really?
I think in a roundabout way of, like, we talk about the gut-brain connection, and when you're eating a more healthy diet, you're going to have that reduction in anxiety, reduction in stress, reduction in cortisol, and then you're going to be sleeping better. So I think, yeah, anytime you're focused on a healthy lifestyle and stress reduction, so you decrease cortisol levels, then you're going to see an increase in testosterone.
And testosterone, doesn't that come from like eating fats?
Or I think that where you're getting that idea is because it comes from cholesterol. That's the precursor. But no, I mean, you're not, like, if you don't have a lot of fat in your diet, you're not low on on testosterone.
I heard something about that. I was like, oh, like, so if people are on low fat diets, like, they would have no testosterone at all. But okay.
Wait a minute.
Now, there's certain exercises that can increase your testosterone more than other exercises, or just exercise in general will lift the testosterone.
The adductors,
Oh yeah,
yeah, that's the biggest testosterone booster.
Wait, are you serious? Okay, I was like, do I have to start hitting those? I refrain from doing them.
I'm trying to think of like the least manly.
It's boosted by.
No, just exercise in general.
okay, because I've seen like
I've heard
Resistance
yeah.
training. So
leg doing squats raises your T the most, but that
you're just targeting more muscle groups than a bicep curl, for example.
Oh, okay, all right, I got you.
What about cardio?
Cardio will increase it too.
Okay.
It's just you have more of an impact with resistance.
How about like supplementing testosterone? Like, I take a testosterone not booster, but kind of like support from Costco, and I like it. It's got ashwagandha in it. Did I say it right?
I think so.
A bunch of B vitamins, but is that doing anything, or am I just paying for expensive pee?
You're probably paying for expensive
Dang
tea.
it.
There is a couple like herbal supplements that have shown significant increases in testosterone. And one of them being Tunget Ali is what it's called. It's a herb that was found to have these medicinal properties and actually help with erectile dysfunction. And then there was a couple different studies. One of them a meta-analysis, which meta-analysis is a study of studies. You can only do these studies when you have enough data to compile them all together. So it's kind of impressive that this Tunget Ali, there's been a meta-analysis to show that it significantly increases testosterone levels. And there's also like a separate randomized controlled trial.
So let's say you start taking this supplement. Now do you start relying on that supplement?
So that gets, I think, the problem with, the people getting super into testosterone replacement therapy. That particular supplement, I don't know, because we don't know a ton with the mechanism of action here. But if you're going to go in and you have low testosterone and you get put on testosterone replacement therapy, TRT, there's a lot of different methods, but most of the time you're getting an injection that's anywhere from 100 to 200 milligrams that you'll inject every 1 to 2 weeks is what most clinicians do. We'll talk about why that's.
Do you do it yourself or do you have to go in?
No, you'll do it. So you'll get these like preloaded vials that you can do the injections yourself, similar to like Ozempic.
Derek Jeter.
And there's also like how is it? Yeah, Nitresto, I think is what it's called. I always forget the names of these things. Nitresto is like this nasal spray. It's a testosterone nasal spray that you do like 3 times a day. There's also oral testosterone, sublingual testosterone.
There's like ointments too.
Yeah, there's ointments. There's dermal patches. There's a lot of different things, but the intramuscular injections seem to work the best because you can control for the dosage. They are not susceptible to what's called first pass metabolism, where it gets broken down when you are taking it orally. And so you can't control for how much is actually getting into circulation. So most of the time you're doing an injection. Now, when you get this testosterone replacement therapy, the cells in your testicles are not producing testosterone anymore because they don't need to. So you get this increased testosterone level. And remember when I mentioned the hypothalamus and the gonadotropin releasing hormone? So that high testosterone tells the hypothalamus, hey, we got a shit ton of testosterone.
We don't need to make it.
We don't need this FSH and LH. And so that axis kind of gets shut off. And then what happens then is the cells in your testicles start to atrophy. And so,
So could replacement therapy actually lead to lower T in the future?
If you come off of it.
Yeah, so you do rely on it.
Yeah, so you have to keep taking it kind of like Ozempic, where you just have to always be on it kind of thing?
Yeah, most of the time you are on it because you're on it for what's called hypogonadotrophic hypogonadism or primary hypogonadism, which is like your gonads are hypoactive, they're not producing testosterone. And so you have to supplement with testosterone there. Now, if you don't have this issue and you're supplementing with testosterone, you're
screwing yourself.
Yeah, and some people will take there's a medication that you can use called clomiphene, which is a androgen receptor blocker at the hypothalamus, and so it will kind of hide the elevated testosterone or estrogen in the body, so that hypothalamus will keep producing FSH and LH. And some people actually use that instead of testosterone replacement therapy, because then it starts at the top and just kind of signals this testosterone production.
Do steroids have the same effect?
So it is a steroid. So testosterone is when bodybuilders are taking steroids, it's an analog of testosterone a lot of times.
Yeah.
Tons of different ones. But essentially, you're trying to increase this steroid hormone
Mm-hmm.
for growth. And people are like, oh, the person's on steroids. That's why they're so jacked. It's like, okay, they're on steroids so that they can work out like a maniac, like 3 hours a day. It's not like they just
And lift heavy the entire time.
Because testosterone helps with muscle growth, helps with recovery. It reduces body fat.
But doing steroids, you're dropping your T eventually once you come off steroids.
Yeah, so a lot of these bodybuilders will end up continuing on testosterone replacement therapy. And so it's dangerous if you're somebody who wants to have kids one day, because you have this testicular atrophy. Those same cells are making sperm, and so it leads to infertility in a lot of people. And so a lot of those people will just stay on testosterone replacement therapy long term.
Probably got in steroids to get big and then didn't even realize they were
steroids,
dropping their T down.
Yeah, I mean, it's much more. We know a lot more about it now in like the bodybuilding community. There's a lot safer ways to do it to prevent these things from happening. And in a lot of cases, it is a part of the sport.
Well, they have, if you're looking at bodybuilding, they have natural and non-natural competitions.
And we won't dive down the bodybuilding thing, but so if you are taking testosterone replacement therapy, if your testicles are producing testosterone just fine, there's no point in supplementing with testosterone. You could have a issue with your hypothalamus or your pituitary not making gonadotropic releasing hormone or not making FSH or LH. And so all you need to do is just signal that, and then testosterone will be made perfectly fine. And in some patients, that's called secondary hypogonadism. So it's not actually the gonads, it's coming from a different area. And so that's where you would use this clomiphene or another androgen receptor blocker, where it just tells that hypothalamus to let's make these gonadotropins, FSH and LH. So when you go in and you get a lab test, you'll want to see, okay, is my testosterone low? And if it is, what's going on with FSH and LH? Because if those are high and your testosterone is low, that means that your nuts are not picking up the signal to make testosterone. That's when you would supplement with that testosterone. But let's say testosterone's low, so is FSH and LH. That's where you'd be like, okay, there's not, this signal from the top is just not coming. So let's target the hypothalamus there and then see if we get testosterone production. So as we age, we get this natural decline in testosterone. And that's where I feel like we're spending a lot of time thinking about, like, if you and I are low testosterone, it's not very prevalent. So this graph that I'm pulling up here is from a study in the New England Journal of Medicine that basically just analyzed testosterone levels among people from different decades of life. And you can see the percentage. So from 20 to 29, I mean, you can see on the figure a very low 5%. From 30 to 39, again, that's around when we have that peak. 2%, it looks like. And then you can see, so I'm looking at the now both low total and low bioavailable testosterone. You can see the increase once you get to 40. And then by the time you're in your 70s and 80s, I mean, over half of the population has low testosterone. And that's where this problem really comes in. That's where this discussion of testosterone should be, as opposed to, oh, it causes you to be infertile. Oh, you're ruining your testicles. These individuals that are aging and have this decrease in testosterone function, we should be supplementing for them because they're having this decreased mood, erectile dysfunction. We talked about sexual health. And we know all these impacts it has.
Muscle loss too.
Function and muscle loss.
Decreased quality of life too.
Exactly.
Yeah. Just,
and so that's, really what I feel like is important to highlight is that, like,
and is this not really like brought up in the medical field? Like, are they not like treating this really well? Because like those numbers are pretty staggering from that graph. Like,
not nearly as much as they
I
should.
feel like this is very important. Like you see it's like so low and then all of a sudden it just spikes. And yeah, you see like old people barely able to function or their quality of life is decreased, especially in males.
Yeah. I mean, Joe, you asked about like, should it be part of a routine physical exam? And I don't know that it should be for, young adults because the likelihood of you having low testosterone is so low. I think that should be very symptom based, but I think I could make a case for
40 plus.
Yeah, as you get in your 40s, like we have colonoscopies, we have these screenings when you're 45, and you
start making a graph of basically your testosterone. Does it stay steady? Is it in the decline?
Yeah.
Do we need to start? Do we wait?
Yeah, and I think that is where the field should head because, we know that testosterone replacement therapy has these incredible health benefits for people as they age. And yeah, we can kind of dive into the impacts there. But
so going with that, if you're working out, right, and you continue to work out and work out and work out throughout your life, you're going to see less of a decline in your testosterone, correct?
Right.
And making sure your stress levels are low too.
Yeah, which when you say like when you're working out, I kind of think of those going hand in hand, like we talked about with exercise. Exercise reduces stress. Exercise improves sleep, which reduces stress. Exercise improves sleep.
Also,
improves appetite.
buying a motorcycle.
And then so like
that's a telltale sign right there.
I feel like when you turn 45, like you should have to go
get a motorcycle. Yeah.
Yeah, like that.
Well, it's 50 or right around 50, really.
Yeah. You can push it off till 50.
Yeah. 45 when you start talking, you're like, man, nice Harley cruiser.
That'd be a good, like, we should get a motorcycle and people can just like come over
and raise their T.
A little spin, a little T-bump.
Little T-bump.
Do you do TRT? No, I got a motorcycle.
I'm good.
So yeah.
No, there's some pretty cool studies though, and like what testosterone replacement does for aging men. And there's a really cool study on just like body composition and trying to decipher, is it testosterone or is it the DHT? Because we want to know, which one of these is having the impact here. Because if we're reducing DHT or dihydrotestosterone in these men who want to prevent hair loss or slow down the BPH, benign prostatic hypertrophy, is that causing an issue? Hopefully not. We would hope that it's just testosterone. And one study that was done did a really good job of figuring that out. And it indeed is just testosterone. And I don't care if you think this is relevant or not, because it is. So they had they had men who had low testosterone levels, and then they supplemented them with 200 milligrams of testosterone every 2 weeks, which is what some clinicians will do in a clinical setting. And then they also, so they had one group that did that and took a placebo pill. And then they had another group who did that testosterone, but also took finasteride at a level that would drop dihydrotestosterone to essentially nothing. And then they looked at, okay, if it's dihydrotestosterone that's causing the impact, then the group that had the finasteride wouldn't see any of these improvements, right? But they did show, so I'll pull up the image here. Now, these two lines up here are the groups that had testosterone, either the T or the TNF, which is testosterone and finasteride. And then here's the placebo, which got neither. And you can see as time went by, what happened to lean body mass. You can't see the y-axis here, but this is muscle mass. So these two lines look pretty darn similar, right?
Yeah.
And they sure look like they're increasing to me. And then the placebo didn't really change.
Yeah.
So it's showing that testosterone increased muscle mass. And then here, this is what happens to fat mass. What do you see with these two lines?
Holy cow. Yeah. It
Looks like it goes down there.
Exactly. Looks like that there line goes down there.
Yeah. That you want?
Yeah, and we'll link to these studies, but it basically just showcased, okay, this is testosterone. Testosterone's playing a huge role in body composition. And we know when we're increasing muscle mass and we're decreasing fat mass, I mean, that could probably have quite a few metabolic effects. And so there is a study that it's a meta-analysis in 2014 that grouped a bunch of these studies on what's happening with testosterone replacement therapy and metabolic function. And it's kind of boring. I hate tables, but when you look at meta-analyses, they always show this type of table here, which this center line here at 0 means there's no impact of whatever you're studying. If it's shifted to the left of this line, if this black diamond is shifted to the left, it means that there is a significant impact of whatever you're studying. And if it's to the right, it means that there's actually the opposite. And so you can see in all these lines, this is a gel testosterone, an oral, and an intramuscular. What happened to circulating glucose levels, which we've talked so much about why you want a reduction in glucose. Where are those black diamonds?
Shifted to the left.
Darn right they are, Reed.
Bingo.
And then you've got insulin, same thing.
Hey, Reed,
Significant reduction.
pretty good at reading graphs.
Dude,
Yeah.
I'm the graph man.
He's the graph man.
Graph man.
And you got the same thing with insulin. So significant reduction in insulin, significant reduction in A1C. And then a cool study that came out of 2021. This is a randomized, double-blind, placebo-controlled, 2 years, phase 3B clinical trial.
How old are these folks?
So let's see. In this study, from 50 to 74 years.
Okay, so when you would start thinking about this stuff.
All of these studies I'm going to talk about now are in the age group that I think should be supplementing with testosterone replacement therapy.
Which is 50 plus.
Yeah, after you ride your motorcycle.
Yeah. You get a little spike, and then once you get used to riding your motorcycle and all the vibrations, then you go check.
All right, so 2021 clinical trial published in the Lancet. So men 50 to 74 years old, they had newly diagnosed type 2 diabetes, and they looked at what happens when you supplement with intramuscular testosterone, what happens to their type 2 diabetes or their ability to regulate glucose. And they did a glucose tolerance test, which is, well, we've talked about that before, where you just chug. Well, both of you have had kids, and your wives have had to do glucose tolerance tests.
I haven't had a kid yet.
Well, you've gone through this process, glucose tolerance test, because you're about to have a kid. Or you haven't, but your wife has. It checks for what's called gestational diabetes. Tangent, doesn't matter. Essentially, you chug a high sugar drink and you look at how well does your body regulate that glucose. Somebody who can regulate it well is going to bring down that glucose after chugging the drink. Somebody who has diabetes, glucose is going to stay high. And what they found is that when they supplemented with intramuscular testosterone, there was a 40% reduction in type 2 diabetes classification. Fat mass went down 6 pounds. Total muscle mass went up 4 pounds. Waist circumference significantly decreased. You essentially saw this reversal of their type 2 diabetes just with testosterone. This is a very highly controlled study. And then as we age, we kind of touched on this in the episode with Dr. Roloff, where we talked about like estrogen, what happens through menopause, and you have this decrease in bone mineral density. Reed, you look absolutely mesmerized.
Just reading.
No.
Just reading.
So we know that estrogen plays a role in preserving bone mineral density. When you have a drop in bone mineral density, you're at increased fracture risk, increased risk of osteopenia, osteoporosis. So we often will supplement with estrogen to prevent that. Now, what's interesting is testosterone also seems to play a role in that. So same thing with men. I mean, you can think of this as like the menopause for men. So there's a 2017 paper published in JAMA, and this was a clinical trial where they supplemented testosterone for men who had classified low testosterone, less than 275 nanograms per deciliter. They use topical testosterone here, which kind of sucks, but still, testosterone supplementation. I'm going to pull up the results here. What happened to bone mineral density and then bone strength they tested. They looked at spine and hip because when you look at these, that's how you classify osteoporosis. So they did a DEXA scan to see what's going on here. And the dark blue is the old dudes who are supplemented with testosterone. The light blue is no testosterone. What do you see as far as bone mineral density in dark blue versus light blue?
Just way higher.
Way higher.
Yeah.
In every single metric they measured. Same thing with strength. So it's not just the density, but actually like the integrity and the function of that bone is way higher. And so turns out we do have this impact of bone mineral density. So you've got the metabolic impacts. So increasing metabolic function, the role that that plays in preventing, obesity, preventing liver failure, preventing cardiovascular disease, all these things just from the metabolic effects alone. And then you get into increased muscle mass, decreased fat, increased bone mineral density. I mean, this hormone clearly is playing an incredible role in our health. And it's a problem that we see it declining and we're not doing anything about it.
Is there a point in time, like age-wise, where it's too late to start replacement therapy? Or could you just hop on the old train?
So in one of these studies, the average age was, this is an interesting study, actually. There was a study that the average age was like 71, and they put on 9 pounds of muscle in the span of 3 years, and just from testosterone replacement therapy. It's not like a highly controlled study, but the amount of outcome variables that they looked at and just these trends are unbelievable. So this is a study published in 2016 in the Journal of Clinical Endocrinology, and it looked at what happens if you supplement and then you go off of the testosterone replacement therapy and then you were to start again. So you had this intermission time period. And so they had 300 middle-aged men on testosterone replacement therapy, and they followed them for 5 years. Half of those dudes ended up going off for a period of time. It wasn't controlled. They actually just went off of it because of cost. But they did compare those half to the half that stayed on it. And these graphs are just nuts. So we'll start with total testosterone levels. And so the green here is people who just stayed on it. And you can see the interruption time period is in red. So this is when they're off the testosterone for just over a year, almost a year and a half. And you can see testosterone's increasing in both groups. Also, it drops all the way back down to baseline.
Yeah.
They start it again and it comes back up. So this is showing, when you stop testosterone, and I feel like we would expect to see that. We stop supplementing, right? This isn't super shocking. But what's happening to all these metrics we're looking at? So the first one, waist circumference. So you can see if you're on testosterone, you're dropping this weight circumference, fat's coming off. As soon as you stop it, shoots
right
back up. You gain all that weight back. And here's weight. You drop this weight, and these individuals were 220 pounds at the beginning here. And so they're not like light individuals, and they're showing this significant reduction in weight with testosterone replacement therapy. But then when you stop it, weight's starting to bounce back. Glucose. So you see the same thing, reduction in fasting glucose. As soon as you stop it, boom, bounces back. I could keep going and going. A1C, same thing, significant reduction, bounces back. Blood pressure. So we haven't even touched on like the cardiovascular effects.
Yeah.
They're showing this 20-point reduction in systolic blood pressure.
Mind-blowing, actually.
Isn't it? And like how mirror imaging all these graphs are. If you take testosterone replacement therapy, if you're low T, not if you have normal T, this is applying to only people who need testosterone replacement therapy. You're seeing this crazy improvement in blood pressure, crazy improvement in cholesterol levels, triglyceride levels, LDL, HDL. It's crazy. Like all these graphs look exactly the same. Like it almost looks fake, right? And again, that's one study, but it
paints a pretty big picture.
It paints a pretty big picture. And then along with all the other data that we have with the impact it has on metabolic function, muscle, like it starts to kind of make sense. Like, oh, yeah, I suppose like if we're having all these crazy impacts, sure, I would see cardiovascular improvements in that. So yeah, get your grandpas on testosterone.
You know how they say like roid rage, like basically steroids are testosterone booster? Would people doing this maybe see a little more aggression?
No, because when you're supplementing with testosterone, you're trying to get into within a normal range. Mm-hmm. So you're not at these hyper physiologic levels.
Okay.
When people get this like hyper masculinity from testosterone, that's because they're taking these crazy doses. I mean, a lot of bodybuilders will supplement with just an unbelievable amount and do it daily. And the problem with a lot of these supplement protocols, you go into the doctor and you get prescribed a testosterone replacement therapy, and you do it every 2 weeks. Now, the problem with doing it every 2 weeks is the most commonly prescribed supplement is testosterone cypionate. It's an injection, and it has a half-life of 10 days. And so when you're doing it every 2 weeks, you've got this significant decline before you redo that injection. I mean, the point is that you can reach the steady state in testosterone levels. So, you want to do it at least weekly. And then a lot of clinicians will do, every 3 days, they'll do these injections at a lower dose. So I feel like we're still not at this like stage where even if you did go in and you got testosterone replacement therapy,
you're going to see it just declines since you get that first injection, right?
Yeah, you want to make sure that you're on a dose that you can achieve this steady state.
Yeah.
And so it's usually a little bit more often. And there's different types of testosterone that we won't get into all that. But
so really the side effects are hair loss and potential with the prostate being enlarged, which you can take inhibitors, right? If you go on this testosterone.
So what's actually interesting, and there's not a ton of research on this, but it's called like the androgen saturation theory, where you've got these androgen receptors that testosterone or DHT bind to. And once they're fully saturated, when you increase the level of testosterone or DHT, it's not having an impact because there's no more receptors for it to bind to. And turns out that the receptors that DHT binds to in the hair and in the prostate, there's much lower receptor density than there is in like the muscle, for example. Okay. And that's why we're not actually seeing this increased risk of prostate cancer like people used to think, or this increase in hair loss, because you're not actually increasing DHT past this point of
You're just getting it to where you need
You're
it.
just getting that good threshold. Yeah.
well,
Get
and
that
even
good,
if you
good.
did increase it, if they're fully saturated, it's not having like more of an impact.
Okay.
And there's some recent work with prostate cancer, and I'll pull up these studies, but um, it there's not a lot of significance. So there's a 2009 systematic review that showed that like a very small percent change that wasn't significant in prostate cancer. But there's some recent work on if you have a prostate cancer that's really aggressive, it actually isn't going to have those androgen receptors. And that's a thing with cancer. When these cancers get really mutated and really aggressive, they don't mimic regular cells at all. So they're not responding. You're just
I'm sinking into this couch.
so they're not responding to these hormones. I think that's going to be an evolving area with prostate cancer because, like breast cancer, it's a hormone-driven cancer. And so it would make sense that testosterone supplementation would increase. But the reality is we're just not seeing that in the data. And so it shouldn't be a reason to deter for testosterone replacement therapy, kind of a risk benefit thing. Obviously, talk to
Other
your
people
physician.
that shouldn't be doing it, like people with heart issues, people with other
Prostate issues already. Even though you said it doesn't.
Yeah, the prostate thing, again, I understand the concern with it, and we'll link to the meta-analyses, the kind of lack of significance surrounding that. Now, Joe, you asked about if there's anyone who shouldn't be on it. That's been a really big area of debate. And it started in 2014 when this study came out reporting an increased incidence of cardiovascular events, so heart attack, stroke, in men who are supplementing with testosterone. There's actually two different studies that came out. And so the Endocrine Society released a statement saying that testosterone therapy shouldn't be used in men who had increased risk of coronary artery disease. But what's crazy is the FDA did this review of this 2014 study in particular, and this study was looking at people with low testosterone and what happened when they supplemented. And they were looking at something completely different, nothing to do with cardiovascular disease. They were looking at like body composition, muscle mass, and they stopped the study because of an increased incidence of cardiovascular events. And what's interesting, that was the 2013 study. This 2014 study, same methodology, but they reported that there was this increased risk of cardiovascular disease in this population. But I'm going to show you the results. And this caused a huge issue. It actually 29 international medical societies, more than 160 physician scientists from 32 countries petitioned JAMA, which is the journal that was published in, to retract the article. They said this is gross data mismanagement and contamination. The study should be no longer credible. So the FDA investigated it and kind of changed their position on it. And I'm going to show you why. When you look at the results of the study, the untreated group with testosterone is in the orange here. Let's focus on all events because that's what they're obsessing over. All events includes just death in general, heart attack, or stroke. So the T group is in blue, the orange group is or the untreated group is in orange. And then percent change in events.
Half.
Yeah, it looks like
More than half, yeah.
They reported that there was this 29% increase in cardiovascular events. We're seeing a 50% reduction.
Yeah.
Yeah.
So that there's this inconsistent data. Well, it turns out they came to this opposite conclusion by changing 50 different variables in their study to basically make these statistics more complex. So
To get to the outcome they wanted.
right. And so there was this big issue around that time. And then a series of studies kept coming out and there was showing the significance, but still, like as the FDA, you're not going to tell people it's okay until you have enough data to say it's okay. So there's a lot of caution. But in 2023, the long awaited Traverse trial is what it was called. It was strictly designed to test this idea. Does testosterone supplementation in individuals 45 to 80 years old who have low testosterone, does that increase their risk of cardiovascular disease? And they showed no significance. And so you can see on the graph here, placebo versus testosterone, what happens to incidence of cardiovascular disease. And there's no difference there. And so I say all that to say, more research needs to come out there, but it sure does seem safe. One interesting thing about testosterone replacement, though. So testosterone actually increases what's called hematopoiesis, which is production of red blood cells. And so you get increased red blood cells, which in somebody who's anemic and has low red blood cells, that's freaking awesome. But if you have a high, what's called hematocrit or percentage of red blood cells, that's actually pretty problematic. Red blood cells are really sticky and they don't go through your blood vessels very well. And when there's a high amount of them, you are at increased risk of these cardiovascular events. So that can be problematic. I'd say, somebody who had a recent heart attack, stroke, and such, you may not want to mess around with that. But it seems pretty darn safe and pretty darn effective.
I didn't know I was going to learn so much today.
Yeah. So we went over all the risks. Are there any other things that you think the listeners should hear about testosterone? If they're thinking about maybe getting checked on it, would you recommend just changing your lifestyle, doing exercise first before going in? Or
100%.
And then if you don't see those boost up, then go seek professional help, like go see your physician?
Yeah, 100%.
Okay.
And that I forgot to bring up too, like when you have increased adipose tissue, so just more fat, you actually increase this aromatization process or the conversion of testosterone to estrogen. So people who have higher body fat have a lot higher estrogen concentrations. Estrogen goes right to that hypothalamus where that gonadotropin releasing hormone is released. And that hypothalamus is like, oh, estrogen levels are super high. Let's shut off this FSH and LH. Well, that shuts off testosterone production. And so, and low testosterone production increases fat mass. So you have this like problematic impact of just body fat on testosterone levels too. Which just a side little tangent there of like, yeah, focus on lifestyle interventions. We know cortisol impacts it. We know body fat impacts it.
Direct correlation to body fat.
Yeah. And we know testosterone increases muscle, decreases fat. So yeah, I mean, if you're a young adult, chances are your testosterone, your ability to make testosterone is just fine.
Yeah, under 40, for sure.
Sure, you might have low T, but you also have the ability to have not low T.
You just gotta get in the gym.
Yeah.
Or on a mountain hiking.
Yeah.
Or a motorcycle.
No, that's later.
Oh, yeah. Yeah. No, that's until you're 45 that you get on a motorcycle. All right, let me just see. Oh, yeah. With bodybuilders, we'll get into this a little bit, but
you said we weren't going to do that.
Yeah, you're right. You're right. Well, if some dude's going to take testosterone,
I'm down to talk about it.
If you're going to supplement with testosterone and you don't need it, you have this increased production of estrogen then, which causes gynecomastia, and you're going to get some man boobies when you have all this high.
Is HGH the same thing as?
Ooh, that I'm glad you. That's going to be more bodybuilding. So HGH is separate from a testosterone replacement therapy, but it's used within like the bodybuilding community or people who have like stunted growth, because HGH causes an increase in growth hormone, which increases what's called insulin-like growth factor. It just stimulates growth. So people who want to get all beefy. But let's save that for the bodybuilding one. It's really easy to tell if somebody's on supplemental testosterone when they go into the doctor, by the way. Like if you get a lab test, like it's so clear. Some people are like, no, I'm not taking testosterone. Their FSH and LH levels are just non-existent, and there's testosterone just through the roof. It's like, you're taking freaking testosterone, dude.
Why would they lie about that?
I don't know. I mean, people like, because it's banned in so many like sports and stuff.
What would you like to leave our listeners with just about testosterone? Just kind of like ending remarks. What would you like to leave it with?
So I'd say there's too much obsession about testosterone in the young adult population who in reality is not going to need testosterone. But there's not enough attention in the older adult population who does need testosterone. So we kind of have this like issue of, and it's similar with women in hormone replacement therapy. We're just not doing enough for those people who we know we could have a huge impact on. So, you know, if you're going in for your Medicare wellness check, toss a testosterone level on there. And if that's low, that's something that's totally manageable in a clinical setting. And it's very safe to do so and has tremendous health implications. Of course, there's reasons why you shouldn't be on supplemental testosterone. So make sure that you're doing this safely, talking to your physician and such. But yeah, I think that we're kind of behind in the healthcare field on this topic.
Yeah, there's just
I would like talking about this topic.
That's interesting. No, that's great.
Yeah.
You know, some people think they got low T when they don't.
Or just change your
And
lifestyle.
or they do, and getting a check of it. I mean, why not start when you're in your late 30s, like I
Just
did,
monitor it.
and
Yeah.
do a monitoring thing, and that way when it starts to dip in, you can be like, "Yo,
Give me that motorcycle."
doc, do you think I should do TRT or just go get a motorcycle?"
Do you think insurance will cover getting a motorcycle?
Yeah.
That's, I mean, the end goal.
Can you
is
think?
trying to get
Yeah,
insurance
get a
covered.
doctor to write me a prescription for a motorcycle.
Harley.
Yeah, so your testosterone came back pretty low. We're going to start you on this medication. It's a 1500 Harley Davidson. I'm going to have you go ahead and ride this 300 miles and then come back in and follow up. We'll see. Sometimes we have to adjust the dose to throw on some A-Pang or handlebars. But, you know, a lot of my patients do start out on the 1500 right away and tends to be a little bit of a rocket. So we can always taper that off and get you on the Honda 800 too.
You just
But
spit that off the dome, dude.
we'll get you started here, and then I'll see you after 300 miles, and we'll go from there.
All right, sounds good. Oh yeah.
I didn't spit that off the dome. Me and Joe were talking.
Oh, you had that scripted.
I won't be telling.
Just really, if you think you have low T, just change your lifestyle. That still doesn't benefit, go see your doctor. But yeah, this was really helpful. This was great.
Well,
Miss you guys.
is that it?
You jerk.
I gotcha.
You guys got nothing. I got nothing.
And if all listeners out there, if you guys have any questions or we didn't hit anything that you guys are interested in, look up kickbackscience.com or go on any social media platform. We're on all of them. Just message us there. Any questions you got or any topics you want us to cover. Love y'all.
Love y'all. Miss you guys.